Welcome dear viewers to the video on topic bioequivalence study by pharmacokinetic endpoint and clinical endpoint. You might be aware for the bioequivalence studies, generic formulations and the formulations after the post-approval changes are required to be bioequivalent to the reference formulation. The bioequivalence is required to be demonstrated to prove that the formulation is with the same safety and efficacy to the reference formulation. The reference formulation can be the RLD, comparator product, innovator product, or it might be the product before some changes, before SUPAC changes. The bioequivalence study can be demonstrated by the pharmacokinetic endpoint BE study and or by the clinical endpoint study. If you compare the pharmacokinetics of the test and reference formulation only, then it is called as pharmacokinetic study, which involves the study of Cmax, AUC and some other parameters. In that pharmacokinetic study, the pharmacodynamic effect is not considered or it is not studied. But in the clinical endpoint study, the effectiveness is studied and clinical endpoint study is performed onto the subjects or patients. And pharmacokinetic BE study can be performed onto the healthy volunteers, healthy subjects, or onto the patients. This is a short video. It will help you to understand regarding these two types of the bioequivalence study. BE study by pharmacokinetic endpoint and BE study by the clinical endpoint. Now see the differences in those two studies. So PK studies and clinical studies. The purpose of PK study is to compare the systemic exposure of the drug, which involves study of the Cmax and AUC. While in the clinical endpoint B study, it compares the clinical efficacy safety at the site of action. Basics of evaluation for the PK study is blood plasma concentrations, and for clinical endpoint study it is clinical response. That means reduction in the symptoms. Applicability of PK study is systemically acting drugs, and for clinical endpoint it is locally acting drugs or some drugs for which the PK study cannot be done, for drugs where PK study will not result into the demonstration of safety and effectiveness. The examples for the clinical endpoint studies are some of the dermatological products, ophthalmic products. Then the pharmacokinetic study is preferred by the regulators when it is feasible, faster, cheaper and sensitive compared to the clinical study, and clinical study is preferred when PK study are not applicable. Duration and cost of the PK study are shorter and less expensive. Then clinical studies are longer because these are to be done onto the patients. We need to wait for the symptom reduction or relief, and it will take longer time. These are more complex studies, and that's why these become costly. Variability in the pharmacokinetic study is lower, and inter-subject variability will be there, intra-subject variability will be there. These are the variabilities which are lower. But in the clinical studies, the variability will be higher due to the subjective clinical outcomes. Examples for the PK studies are formulations like tablets, capsules, injectables. And clinical endpoint studies are like topical creams, inhalers, ophthalmic drops. Endpoint measurement in the PK study is Cmax, Tmax, AUC. In the clinical studies, the endpoint will be clinical efficacy scores, lesion count, symptom scale, and some other parameters. Then in the PK study, the number of subjects are fewer based on the power calculations for the pharmacokinetics of the drug, while in the clinical studies, the number of subjects are more. And this is because in clinical endpoint study, more subjects are required to be recruited or taken into the study to account for the clinical variability. So these are the major points to consider for bioequivalence by the pharmacokinetic study and bioequivalence by the clinical endpoint study. When the pharmacokinetic study cannot prove the bioequivalence, cannot prove the similar safety and effectiveness, or it is difficult to show the same similarity, that time clinical endpoint study is to be done. For example, one tablet containing the drug for diabetes, you can study it by pharmacokinetic endpoint BE study. You can administer that drug, it will get dissolved, then absorbed into the bloodstream. You can take out the blood sample, plasma sample, and measure its concentration in the blood, and then you can show that the pharmacokinetics are similar for the test product compared to the reference product, and that's why I can demonstrate the safety and efficacy. But if the drug is locally acting into the gastrointestinal tract or GIT, so that local effect cannot be captured through the PK studies. If that drug is not getting absorbed, but it is acting locally in the GIT, or you can consider like dermatological formulations, topical creams, gels, ointments. So how you can show that the product is equivalent? So if you cannot show the equivalency by PK study, then you need to show through the clinical endpoints, through the relief of symptoms, reduction in the symptoms. This is the basic understanding for the pharmacokinetic BE studies and pharmacodynamic or clinical endpoint BE studies. Clinical endpoint BE studies are always performed with the placebos because you need to compare the effect of the active drug with the reference formulation or with the placebo. I hope this video will give you understanding about these two terms. If you are not getting more information, you need to watch all the videos related to this topic so that your understanding and knowledge will get improved. I request you to go through the channel playlist to clear your doubts and to enhance your understanding. Thank you for watching the video.